So I'll do a slight attempt at introducing Dr. Jessica Haber and Dr. Kalebi. But to begin us off, basically, so welcome all of you to today's webinar, part of the Ajua webinar series, which we call Stay Alive series, a series of campaigns. So today's webinar is about making decisions with data in healthcare for COVID-19 pandemic. I believe none of us on this call, at least, have been alive during a pandemic before, especially at this scale, at this global scale. So it's quite new to all of us, and the importance of data, I think, is something that cannot be, I would say, overrated. Why is that? I think we live in the world where IT or technology has now at least exposed us to so much data, but how to interpret that data to helping us stay alive or keep alive and stay safe is something that really will make a difference, whether it makes sense for us, for our livelihoods, for our families, for our businesses, for organizations, or it doesn't. So as consumption of that data, how we use it, how we help, we use it to help make decisions. Those in authority, those in organizations, or on personal health as well, is quite critical. So to kick us off will be Jessica. So Jessica Haber is an MD, which is a doctor, really doctor, medical doctor, right? Certified in San Francisco, California, and affiliated with Massachusetts General Hospital. She got a bachelor's degree in biological sciences and a master's degree in health sciences research from Stanford University, as well as a medical degree from Yale University. So I think I just read 3 degrees right there, Jessica. So Jessie is not new to Africa and specifically to Kenya. She's been to Kenya a couple of times, and especially under the HIV/AIDS initiative around working with KEMRI and a couple of other institutions as well. So she'll mention a couple of things around that in terms of experience, especially dealing with situations such as what we presented with regarding the coronavirus. And working on this webinar today with Jessica is our own Dr. Ahmed Kalebi, who's the CEO of Lancet Laboratories. I will dare say Lancet is the biggest laboratory set up in Eastern Central Africa, if I may say so. Maybe, probably across Africa, the most expansive. What you don't know about Kalebi is that we were in school together with him.
6 years.
For 6 years. And what also you don't know is that I did help him get married, and I still married that one lady. And his wedding was one of the first Muslim weddings that I actually ever went to, and we ate quite a lot. So Ramadan Kareem to you as well, and to your family.
Thanks,
Dr. Kalebi. And our apologies for bringing you out. You should be home now, going home to break your fast. But thank you so much for being with us today. So Kalebi also is quite distinguished in pathology as well, and is one of the biggest, or they all say the greatest pathologists we have in Eastern Central Africa as well. So let's move on to Jessica, and Jessica, a little bit, tell us a bit more about herself as well, and Kalebi will do the same as well, of the things that I could not mention in the interest of time. So Jessica, over to you, please. Thank you.
Okay, thank you so much for the opportunity to be with you all today. I can't say here because I'm at home, but it's nice to be with you in the way that we all gather now. So I will include some of my introduction in a couple of slides. So I'll just begin with my talk, and we'll get to that shortly. So here's our Stay Alive campaign. Just a few disclosures, which I usually make with all of my presentations, so you know where I'm coming from a funding perspective. I'm fortunate to receive money from my research. I do work a bit with industry, but I have no conflicts to declare. And the talk today is to think about the experience, that we're in with COVID around the globe. And I've heard lots of references to other pandemics and diseases. I think many of you probably know this book, Love in the Time of Cholera by Gabriel Garcia Marquez. So I think we're now in uncertainty in the time of COVID, which I'm not authoring, but I do hope to give you a few insights from the way I've been thinking about it and sharing the perspective that we have here in the US. So this is a brief outline of what I'll cover in the next 15 minutes or so. A little bit more about myself, some clinical questions I think we're all facing today, what we've been able to learn so far from past epidemics and our experiences to date, why data and good data is so important as we think about what to do under these circumstances, but also thinking about how to use that data and some limitations that we're facing just because of the pandemic situation. And then I'll give you a few examples of some work I've been able to do in Kenya in the past couple of years and things that we were hoping to start, but are having to retool a little bit under the circumstances. And then a few parting thoughts. So as you heard just a few minutes ago, I am a physician and the Director of Research at the Massachusetts General Hospital Center for Global Health and an Associate Professor of Medicine at Harvard Medical School. Most of my time is spent, oops, I don't know if you can see all of my screen here. Most of my time is spent studying HIV and tuberculosis. I've been doing that work for about 15 years. I started off in Asia and then started partnering with folks in Africa about 12 years ago. So I think I've probably been to Kenya about 20 times and I've spent a lot of time in Uganda, South Africa, other places as well. So I like to think of myself as a global citizen. And I've partnered with Ajua I think probably since about 2012 when you were on survey, so a long-time collaborator. And this is what I look like when I go to work these days. So I do see patients. We were chatting a little bit earlier about what it's like working in the hospital, seeing COVID patients and trying to practice medicine these days. And it is pretty challenging. But I'm focusing today mostly on data, but just to give you a little background of where I'm coming from. Can you still see my slides okay? I just got a warning about my signal being weak. We're okay? All right, great. So just to think about some clinical questions, and these are questions that I've been talking about just in the past week with people at the hospital where I work. And that we have a number of clinical trials going on thinking about ways to treat COVID, looking at antivirals like remdesivir, hydroxychloroquine, I'm sure you're familiar with as an antimalarial. We're looking at convalescent serum, you know, many different therapies that hopefully will help people with COVID. But we're also looking at questions about diagnostics. You know, many of our PCR-based viral tests, we're using those to assess COVID in the acute situation, but they're not as sensitive as they should be, only about 70%. And people are wondering about antibody serum testing to see, you know, what are we looking at in the future in terms of immunity and being able to get back to normal life. We're also looking at equity. There's a big difference in how people are treated for a variety of reasons that shouldn't be there. So this is just a smattering of questions that we're thinking about. But as we look to answer those questions, we have to consider what are our traditional study designs and what are the data that we're going to be able to access to answer these questions. And I think with the first row about the potential therapies, there's really very little flexibility there. And we'll come back to that in a moment. But we really need randomized controlled trials in clinical settings, working with laboratories. I think that's something that we're managing in the hospital with all of our usual protective equipment and you know, just addressing the difficulties, but I think we're having to adapt within that environment. But when we get to these other questions like utility of diagnostics or the equity concerns, we have different study designs that we can use, like cohort studies, looking for correlations between the titers with the antibody tests and clinical outcomes. For equity work, we can just look at databases, chart reviews that are often electronic. These types of questions can be answered in the COVID era. And I'm highlighting the way that we can do this remotely, which I think hopefully speaks to many of you on this webinar. I think we're all united in our interest and use of mHealth and different ways of being able to collect data. So switching over a little bit to Sub-Saharan Africa, and you all are much more the expert than I am, being an American myself. But as mentioned, I've worked with many colleagues in your part of the world. I imagine from the experience that we're having with such a high burden here, and hopefully you won't have that there, but our experiences may be able to provide some guidance with management that we're developing, as I was saying in the last slide. But I think more of what I'm hearing about from my colleagues in various parts of Africa are having to do with the effects of COVID, the response, not so much the disease itself. So people not coming in to deliver their babies, people suffering at home with injuries or even heart attacks or other things like that. And we're certainly seeing that here. People are not coming in anymore. Like, we know that appendicitis still happens, but people are not coming in. So what does that mean in how we deliver healthcare, and what's that going to look like when hopefully one day we're in a post-COVID era? There are probably differences in disease prevalence. The levels of anxiety that we're seeing in my hospital are off the charts. And how are we going to deal with that as healthcare providers? How do we know even what's happening when people are not able to leave their homes? And then chronic diseases where people need to get medicine every month. They need to come in for certain treatments. What's going to happen with that in the COVID era? And more importantly, beyond just knowing what's happening, we need to know what to do about that. And we'll come back to that in a few slides. So in thinking about what to do in the current situation, it's always good to think about history. What can we learn from similar experiences? And I don't think we have had something like this probably since 1917 with the Spanish flu, when none of us were alive. But looking at more proximal events that maybe not on that same scale, I've highlighted here just a couple of papers that I came across on a quick search of SARS. MERS is a Middle East respiratory syndrome. There are other viruses that are similar to COVID that we can learn from. And as you can see listed on the slide here, I think there are lots of things that we can consider in making this less of an impact on us by using surveillance, by being transparent in reporting. I think it's always easy to look back and think what should have been done in December, January. But I think it's clear that the more we can share our experiences and what we're learning about COVID, the better. This should be done rapidly, looking at public health control measures, looking at the development of treatments, as I was saying before, and also highlighting where the weaknesses are in our healthcare systems and public health infrastructure, because these only get worse. As the times get more dire and people are stretched with their own abilities and their equipment, we see these weaknesses come to the forefront. So we need to know how to manage them. And getting prepared to do so. And I think the common theme here is that we need ongoing data collection, we need ongoing sharing of data, and we need to know how to use data in the best way possible. So I won't make this political, but it's hard as an American to not mention our president.
You have already, but move on.
So we all know that poor data can lead to serious consequences. And without knowing, the outcome of those randomized clinical trials that I mentioned a few slides ago, we can make some big mistakes. And we've actually seen a lot of deaths and harm from some recommendations that come from having poor data. So let's think of an example of how we can adapt to the COVID response. And this slide's a little bit busy, but just to walk you through it, I thought it was a good example that may resonate with who I imagine is on the call today. So these are made up numbers. I just completely fabricated them on a quick Excel chart here. But if you could imagine something that you're doing in your work, whatever type of job you have, and think about this blue line. This is how you were going along, and then all of a sudden, March came and the COVID response started, and your production dropped dramatically. And we're thinking now about, what can we do with data? And we'll talk about some examples of things that can be done. But you make an intervention here, and things start to get better. But how do you interpret that? How do you know what that impact is? And I don't know if, August is when this will lift, but let's say it's sometime around then. You may be measuring this difference here, but what you really should be doing is looking back to this orange line, which is what would have happened, say, last year, trying to get rid of seasonal variation, that sort of thing. But we really need to be thinking about this as our comparison and not necessarily this. So it's just a simple example of ways of framing questions in the time of COVID and looking at certain designs that can help us in doing that. This is a natural experiment in many ways, but it's a challenging natural experiment in the sense that we don't have a control group. You know, there's no counterfactual to say doing it this way is different than doing it that way when none of us are able to not be in this circumstance. So some limitations to consider. When we go out to collect data, we normally just go out and do it, right? We get consent forms, we enroll participants, but this is a different time. You know, we can't necessarily leave our homes. People coming in to do procedures and things like that may be vulnerable to getting COVID. So we need to make sure that what we're doing to help understand our circumstances and improve what we try to do in our day-to-day lives doesn't put people in harm. So thinking about the ethics and the equity of our research is really at the forefront. And I think one way to get around a lot of these problems is through remote data collection. Am I doing okay on time?
You're doing okay, thank you.
All right, so, and I'm shifting now into thinking about ways to collect data remotely. And I'm probably preaching to the choir here, but I hope this is resonating with many of you in the work that you do. You know, the availability of data now, I think can speak to what we're able to do with it going forward. But having access to things like electronic medical records or any kind of electronic data helps us get that prior chart. You know, it gives us this orange line here to help us understand what our real reference point is. Obviously at Ajua, you know all about phone calls and SMS surveys and ways to collect data and in that manner. I do a lot of qualitative work to understand the quantitative implications of my research, and we used to think that you couldn't possibly do a half-hour interview and really get to know what's going on with somebody over the phone, but we're finding we can in a lot of ways and get some really good data that way. When allowed by legal and public health circumstances, using couriers to collect self-administered dried blood spots at home or other ways of getting laboratory data that we would normally not do, but that could be possible with remote data collection. And processing in the lab here, I see the next speaker has a microscope at the ready. Here it's actually really difficult to get anything done because people aren't allowed to go into the lab. They aren't allowed to go into the office, but someday they will be, and we can have those samples at the ready so that we can learn as much as we can from the current circumstances. So in the last few minutes, I'll just go through a couple of examples of ways I've been using remote data collection and remote interaction with people even before COVID, but I think these are models that we can consider going forward. So Prep My Way is a study that I was actually planning to be in Kenya this week to launch. Yeah, so you guys are giving me the opportunity to be there in spirit. But I was actually meant to be there literally today, meeting with some of these partners to launch the study. And we will do it at some point soon. But this is a study about PrEP. So many of you may have heard of PrEP. It's a medication to prevent HIV infection. It's something I've been involved with since the very early stages, the phase 3 clinical trials, to make sure that this works. And we do know it works, but it's very dependent on adherence. And a priority population is young women, specifically in sub-Saharan Africa, which are currently highly vulnerable and have some of the highest numbers. And so we planned this study along with Dr. Bukusi at Kemri and a few other of my colleagues in the US and a design partner named ARC Africa in Nairobi. And what this study is really meant to do is to understand how to promote PrEP and some related bundles of sexual health for young women, and specifically in Kisumu, where the study is planned, knowing that there are lots of stigma and structural barriers that prevent young women from accessing PrEP. And so what we're planning to start at some point soon, hopefully, is to use a human-centered design process to develop a peer-delivered, community-based program. And you can see listed on the slide here the services that we hope to offer, like PrEP itself, HIV testing, which goes along with it, Also doing sexually transmitted infection testing with self-swabbing, or we're hoping to pilot some point of care tests that have recently been developed, as well as providing pregnancy testing, even self-injection of hormonal contraception is available. And these are ways of demedicalizing health services that can be done without bringing people into health clinics. And all of this care is coordinated through WhatsApp and through SMS. And we can adapt that so that we can not only deliver services, help people understand how to do this in the home or wherever they'd like to get the services, but we can also collect the data in the same way. And similarly, a study that we were planning to disseminate to the community this week, that was the other part of my plans for the trip to Kenya, which will also have to be done at a future date, is a study called Untitled, which is monitoring pre-exposure prophylaxis in young adult women. The W is silent. But in PIA, as you all know well, it's new, and this is a new technology, a new medicine, but we're also using new technology to study how women were taking PrEP over the last couple of years. And we partnered with Ajua to do SMS surveys to understand how they were doing with adherence. And this was a study of 350 young women, 18 to 24, in Kisumu and Thika. And we were able to use a device here. This is called the WisePill device that monitors every time it's opened and closed, just as a proxy for medication adherence. And we were able to understand what was going on in our participants' lives on a weekly basis by sending them surveys to see if they felt at risk for HIV. Were they using PrEP in a way that would prevent infection if needed? And it's really quite novel. I'll actually be presenting this work to the National Institutes of Health in the US next week as a new model for how we can really capture the behavioral data along with the biology and the virology in ways that we really haven't been able to do before. So I think I do need to pass over the baton. So just a few last parting thoughts. As we think about providing care in these ways, collecting data on the care that we provide, just want to highlight the importance of implementation science methodologies. I'm sure many of you are familiar with this. It's often what we do in regular practice, but to really collect the data in a rigorous way, I think is critical for understanding the feasibility of what we're proposing, how well it's being used, how valid these new approaches are compared to some of our old gold standards, and again, to emphasize the ethics of what we're doing and making sure that it's acceptable given concerns of privacy and other factors that may be different outside of our usual clinical environments. So as a final thought, my recommendations are just to make sure that we're collecting good data in readily accessible formats, and to understand resource utilization, to continue to think about clinical outcomes, tracking this data through the remainder of the pandemic and the future waves that unfortunately are likely to come. And then just exploring the novelty of the moment and trying to find those silver linings in the midst of this tragedy that we're all dealing with. And so with that, I'll just remind you to wash your hands. And I'll pass the baton over to Dr. Kalebi. Thank you.
Thank you very much, Jessica. If you could just leave us on that screen, the blue screen. Just to introduce, and before I do that actually, so thank you very much, Jessica, and we'd like, if you have any questions, please, in the audience, just for Jessica, especially for now, before you forget them, please put them in the chat. We'll get them all answered at the end. So please put all your questions in the chat. You know, while they're still fresh from Jessica's session, and then we'll go into Kalebi. So Kalebi is the MD or CEO of Lancet East Africa, like we mentioned already, and also he's a lecturer at the Department of Human Pathology at University of Nairobi, president of International Academy of Pathology in East Africa, founder trustee of AIBA Foundation, blah, 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 so many stuff, as well as a loving husband to Kamari, who I know very well, and father to some 4 tribeless kids. Kalebi, please, over to you.
Hi, G. Hi, everyone. First of all, I must give a disclaimer that I have zero experience in data and data mining and data-driven decision. The extent that Ajua works on, I'm not a researcher. I mean, I do a bit of research here and there, but I'm more of a practitioner. I run a lab. I see patients, and I do more of the practical day-to-day things. But I guess that also puts me in a position where I have a lot of data that can be used by many people, and I probably that's why Dr. Sagia invited me. I have been sharing quite a bit of data on my Twitter and Facebook and LinkedIn, basically from the beginning of this epidemic, looking at trying to look at where we might be going from a personal perspective. And I think what I'll just mention, I'll probably take about 5 minutes, just 5 or 10 minutes, just mentioning a couple of points that came to mind. I'm not very good in preparing slides. So Jessica, thank you very much, at least for having some slides. I'll probably prefer to have a more interactive session, but there are a couple of things I want to say about this particular topic. How do we have a data-driven decision-making? And I'll speak about it from the context of Kenya and probably East Africa. As Dr. Sagia mentioned, I have laboratories in Kenya, Uganda, Tanzania, Rwanda, and I'm quite I have East Africa quite close at heart. And I've been comparing how we are performing in Uganda, Kenya, Tanzania, and Rwanda. Now, as you all know, Uganda took a quick decision right at the go and said nobody moves in. If you come into the country, you must go on quarantine. There was a bit of an uproar, but once it was said, that was it. And now 4 weeks, actually not 4 weeks, we are now at about day 40. So you're looking at 5 weeks to 6 weeks down the line. You can see the difference between the chart in Uganda and Kenya, Tanzania, and Rwanda. And that goes to show you about the issue of data. In Uganda, they realized that other countries that were having travelers from Europe and China were getting more cases. They took a quick decision. They didn't wait for the impact. And today, Uganda has the fewest number of new cases a day. Actually, all the new cases that had, like yesterday, they had 11 cases. These are all people caught at the border. The other thing is Uganda took a very important decision right up front to target screening of truck drivers. From experience with HIV, we knew truck drivers are among the super spreaders. And you can expect the same thing because there is a lockdown in Uganda. A lot of countries have travel restrictions, but if truck drivers are moving across, that means they can easily be super spreaders, and it has paid off. I think that goes to show you that decisions can be made on historical data, our experiences in the past, and trying to project what's going to happen with the future and what other people have experienced. So I think for the COVID response, one of the fortunate things we've had in Africa, and I really am grateful for this, is because we are lagging behind other countries. So it started in China. They did this massive lockdown in Wuhan, and we saw the results. Now we can see what happened in South Korea, what happened in Eastern and Western Europe, what's happening in America, and we can learn from that. And if you try to learn from that, in fact, there's a very nice paper which was in the Wall Street Journal this week, where they're comparing Eastern Europe and Western Europe. Of course, Western Europe is more advanced. The UK, they had all this issue of herd immunity and so on. While in Eastern Europe, they knew they had poorer infrastructure for health, and they decided to go the medieval way, as people are calling it, in terms of the old way of basically quarantine and restricting movements. And today, if you compare UK and some of those countries, UK has thousands of deaths, basically hundreds of deaths every day. You go to Eastern Europe, you're talking about less than 50 or less than 100 for the last 8 weeks. And again, that goes to show you how decision-making is key. And as somebody said, this is the moment where the world leaders will be counted. The decisions they make all the difference. And from my perspective, from a lab perspective, I think the main issue there is the aspect of testing. As Tedros, the Director General of World Health Organization, said, if you don't test, you don't know. You are operating blind, because this is an invisible enemy, as we call it. You need to know what is going on. You need to test. And unfortunately, we've had a bit of a problem in East Africa and in Africa in general, because although we lagged behind other countries, but since they are most affected, then it was a matter of the highest bidder for the resources. You talk about reagents, consumables, you talk about equipment. So for about 3 or 4 weeks, we couldn't get test kits across in most of the African countries. So for a long time, we could only depend on WHO, which was quite limited. And that has had an impact, because as we speak, I'll probably end on this point. We're looking at the issue of flattening the curve. What decisions do you make? In Rwanda, they decided to lock down the whole country. For the last 4 weeks, it's been in total lockdown. And the reason why they made that decision is because we know Rwanda has one of the highest air traffic per capita in terms of they have a big transport hub. A lot of people are coming from China and the rest, and they decided they're not going to close the airport, but at the same time, close the country from any potential community spread. And it has paid off. In Kenya, we dilly-dallied in terms of the decisions. It was taken in a stepwise manner, but I'm not so sure that that decision was made based on data. And without testing, then we cannot be able to know. So as we speak, should we close Mombasa? Somebody just reminded me that about 3-4 weeks ago, I actually said Mombasa was going to be a hotspot. And the reason why I said that, because we started doing testing in our lab about 4 weeks ago, sending samples to South Africa, and about 3 weeks ago, doing tests in our own site here in the lab. And I could notice that it's expected that Nairobi will have more cases because it's a bigger city and it has more traffic. But what was strange was we are getting these sporadic cases from different parts of Mombasa, and they're not insignificant. So it means that if you're getting sporadic cases from people who have not traveled, that means there's community spread going on. And people need to understand that the community spread can go on for a while as a lag phase before it starts shooting up into an exponential phase. And right now, I think Mombasa, we're going to that direction. But all is not doom and gloom. That's what I would say. I think a lot of the measures that have been taken in most African countries has actually paid off to flatten the curve. We are very different from Spain and Italy for that matter, because in most of those countries, they kind of ignored or took for granted most of the measures that were being announced. And by the time they're actually going for lockdown, it was too late. In our country here, actually, other than Tanzania, and I think Tanzania, make no mistake, will pay a price for it, unfortunately. We are seeing a flattened curve. In other words, we're not getting this exponential rise. What I will say is finally, probably what needs to be done is the decision of when do we open up, because we cannot live like this indefinitely. When do we open up? And Jessica mentioned the issue of antibody testing. In my view, the antibody tests, we have a few that we're validating in our lab here. They are pretty useless. I mean, we have about, I'm collaborating with other labs across the world, and there are about 25 test kits that have been tested for antibodies, and most of them are pretty much useless. The few that are good enough are not that good, which means you can't actually rely on them. I think what is key now is how do people go back to normal life? Dr. Sagia is in the IT world. I know of one of the companies that is our client, and they have opened a campus because they needed people to go back to work, and they do testing before you go back to the campus, and you are in quarantine for a while and you are locked down. There is another group that I'm working with that in the airline industry, and all their pilots have been tested and they are basically isolated from the rest of the world, and they have to go through a safe corridor to determine wherever they are flying. And the same thing has just now started with Kenya Airways, for example. They're having chartered flights to Europe, and you get tested before you travel. And I think we'll probably need to see something similar, because in my view, if, for example, Garissa in northeastern Kenya has never had any case, and there is no single case, it means you can literally ring fence Garissa, control who comes in and out, but people within Garissa can live normally. But if in Nairobi, you go to a particular neighborhood in Isili, and you know that it's a hotspot and there are many people, then you literally want to lock down everybody there, and they must remain in the houses, and literally food should be taken to them, not even going out to buy food. So these are the things we need to find out. We need that information. We need the data so that it can drive the decision we are making. Otherwise, we might be spending a lot of money and resources in things that are not relevant, while the more important things, we're not putting money into it. So I'll stop there, and hopefully Dr. Sagia and Jessica can guide some discussion and questions, and I'll be happy to answer as much as I can.
Thank you very much, Dr. Kalebi. And I want to just, before I go to the questions that could be on the panel, so please, we're going to read through the questions you have in the chat group or in the Q&A. So coming up there just now, shortly. But before I do that, I just want to pick on the last point you mentioned, Kalebi,
Yep.
Limited resources. In Africa, there isn't just enough resources to do everything you want to do, right? Other countries do have or could have that, right? So being that may be, right? So I think the importance of data could be more amplified, especially for African context, just because you can't just throw all kinds of resources you have at one problem. You have to be very smart about how you execute on it. So Jessica, regarding surveillance data, you mentioned something about surveillance data and the importance of surveillance data. We're seeing, a bit of disparities across East Africa because, how many are testing, how many are being tested. Some countries are testing less per capita than others, and therefore we really don't know what the real numbers are. And therefore the transparency across board, there's a bit of mistrust actually, regarding that whole transparency part of it. So how will you place the importance of surveillance vis-a-vis the fact that there's limited resources to actually do just broad surveillance?
Well, I mean, it's an excellent question, and we're struggling with it too in the US because it's probably made it into some of the global media. Different states in the US are handling this very differently, and some are saying we can reopen as of actually today. Some states are actually reopening business, and we really have no idea what the situation is like there. And of the data that we do have, we're still seeing increasing cases. But people are really balancing, the economic consequences of the COVID response with the disease. And in terms of, the use of resources, I think there are a couple of ways to think about it. We started off rationing testing because we had to. We had becoming available because the resources to them, and people are getting very creative. Probably entrepreneurs and used to thinking innovatively about ways to make resources go further or to come up with new materials for making different reagents or tests or things that can help us do surveillance better. We can do surveillance with symptoms just by reporting. We can look at some of these tests that are being developed. And I can't speak to the specific tests, but I've seen the same problem that you described, Kalebi, about the quality of the tests. I've heard of 40 antibody tests we're using, but once we can get good tests, antibody tests can be produced for about $1 US, $2 US. They can be very cheap. So instead of looking at a PCR-based test, which is what we're using for acute infection now, which costs, I don't know, probably $60 or $70 US, if we have good quality $2 tests, I think we can do so much more than if we're relying on expensive technologies. So I think there are lots of ways we can look at resource limitations. I think the ingenuity and creativity, especially again, of people who are used to thinking this way, can really help us move forward as this new reality plays out.
Yeah, good to know that, especially, once you get a quality test, right, antibody especially, right, the $1 even global are easier for donations as well. So the next two questions are for Kalebi on the Q&A. So I just want to ask one more to you, Jessica, before I move to Kalebi. You mentioned something quite interesting in your experience on HIV, the PrEP and the was it MPA, right? Umpia, sorry, about human-centered design, right? Demedicalizing health services. Because most often, we take data, then we have action, but we forget that there's actually a human being who can be completely, right, unpredictable, right? So, and we've seen that in Kenya as well, where we have, some can say it's predictable, but I would say it's unpredictable, but that some will just disappear and run away from a quarantine and take off, right? They know they could go infect your own families, if they have it, but they'll just take off, right? Highly unpredictable. So how do you look at your own experiences, because you're further down, down this road for COVID than Kenya is, and you're starting to deal with some predictability of the human part. How do you see where that whole demedicalizing and around human-centered design, so that you have the data and you have the action, how do you make people actually do what you want them to do? Because, you can make a decision, but there has to be action by somebody else after the decision is made. So how do you see that, and what are the learnings that you've seen so far? When because you're down the road more than we are.
Yeah, it's an excellent question. I think it's something that I've been exploring in my research around HIV and TB. But I think you're right that this is something that we can be applying to COVID. And at the core of human-centered design is the human. And just what I've seen in interacting with patients, you know, coming into the hospital because of symptoms or anxiety, or just really not knowing what to do. You know, we're all figuring this out from the, you know, experience of having the disease to figuring out how to treat it. And so I think we have to look at our solutions through that lens and talk to people about what is it like to get tested? What is it like to use that information, and to not come up with a solution and then figure out what question we're answering with that solution. It all has to be done together with the end user. And I think many of us have started to think this way in the work that we do, but I think it really does need to be at the forefront of our response. Because if we're coming up with a great solution that makes no sense for the people who are using it, we've really gotten no further.
Exactly. I mean, we need to learn first. And I think in Africa, or especially in Kenya, we need to really learn first about that human part, the predictability of the decisions that we'll make, you know, irrespective of the decision that was made earlier. So, Kalebi, two questions for you that I'm reading off the Q&A. So again, reminder, please put your questions in the Q&A so that we can easily read it out for you. One is from an anonymous attendee, and the other I've got a name. So I'll start with anonymous first. Kalebi, so this is about a question to you asking, why is it taking the government of Kenya so long to lock down Mombasa and Nairobi? You're not government, but I guess you can hypothesize why, you know, because we see a lot of this traffic. And how soon do you think as a country we'll be safe enough to get back to normal life, taking into account the government's response or lack thereof? You know, so what do you think about those two?
So about Mombasa, I really am a bit perplexed because we mentioned this more than 2-3 weeks ago that Mombasa was a potential hotspot, especially after the deputy governor's incident. Although it was in Kilifi, but most of his movement was actually in Mombasa. And of course, the governor in Mombasa also publicly called out for a lockdown and started making arrangements for feeding the poor and the needy. But for some reason, the decision was not made. I suspect it has to do with political sensitivity and security concerns, considering that Mombasa is actually a port of entry, supplying a lot of things into the country. But personally, I really don't know. I think Nairobi and Mombasa should have been locked down way earlier. I don't know whether it is, maybe there's some more information that we know. But one of the things I personally think is that the logistics and the considerations in a lockdown, if you look at countries like in France, where our parent company is based, there was a lockdown, but there was already social, economic measures to support people in the lockdown. I think that was lacking here for us. You can't lock down and there is no way of distributing food, distributing water. And I thought that the government was working on that. And by the time they come up with this national response team, then they'll move to lockdown, but it still hasn't happened. I think the more we wait, the worse things can become. Now, the second part of the question was, which is related to the same thing of lockdown. When can we resume normalcy? When can we expect normalcy to resume? I think we just need to look at other countries. America, UK, France, Spain, they all had their lockdowns, whatever restrictions they have in place, about 2-3 weeks earlier than us, or 4 weeks. And despite having gone through another 4 weeks, they're still extending their period. So if we are lagging 4 weeks behind in terms of the curve, it means we can expect that at minimum, when they finish their lockdown or they lift up their travel restrictions, we will probably be another 4 weeks down the line, because our curve is still going up. If you look at the numbers of cases per day, they're still going up. Fortunately, it's not too many in terms of, it's not escalating, but almost constant. You're looking at maybe between 10 and 20 new cases a day. If it remains like that, it means our curve is a gentle slope, not quite flat like South Korea, but at the same time, at least it's not the huge surge that we saw in Spain. So this is basically to protect lives. You don't have an overwhelming of the system, but it doesn't mean that people can reintegrate. And unless a vaccine comes, which is way far away, not less than a year, Or we have better ways of segregating people. That's where data comes in. And I'll give this example again from a social perspective. We have certain people who are critical for the economy to move and for things to work. Like in Uganda, they took a decision that there was no public transport, no private vehicles on the road, basically to remove movement. But then just a few days ago, President Museveni announced that they'll allow borders to operate in restricted time, and not for carrying passengers, but to allow food and because borders are the main couriers for things to move around, and they'll be given restriction in terms of how they can operate. So they're actually trying to bring back some certain things. And I think this is what Kenya needs to look at. What do we need to shut down completely? What do we need to allow back and in a limited manner? Because I'll just give an example. If you have a critical sector like manufacturing, there are some certain manufacturers that are not going on, or constructions for that matter. Now, those guys, it might be cheaper to test them, put them into isolation where they can work and the economy can move, than to go around just testing everybody. You can have this targeted testing. So if we do that, I think the earliest, my personal view, the earliest we can expect some semblance of normalcy is not less than 2 months, not less than 2 to 3 months.
Okay, thank you for that answer. There's another related answer, but more focused on testing, which is really your area, right? In terms of tests or lab tests, right? So in terms of these special groups like truck drivers that are just scooting around the country, especially if we talk about Kenya, but they're being only nabbed by the neighboring countries, right? So, I mean, I'm going to twist this question, you know, to be more specific, what has not, you're not answered already. What can you do? What do you suggest, being a lab person, right, running East Africa's biggest lab setup, to sort this out, right? I mean, you know, are you able to do mobile testing? You know, can you set up something where these truck drivers are moving? Because it looks like this corridor is a hotspot corridor.
So
in the Q&A.
Yeah. So basically, I mean, the WHO has actually come up with what they call laboratory testing strategies, and we can actually borrow a lot from that. And I think each country needs to come up with its own strategy for testing, because, as you said, we can't be like Iceland, where we can test massive number of population. We have to be a bit more focused. Now, in South Korea, for that matter, and I say we can learn from others, in South Korea, they decided that they will test everybody for free who has a travel history or who have symptoms that are related to COVID. Now, but they also said, we will open up testing to anybody and everybody who wants testing, but they'll pay for it. And they pay something like $120 to $140. If you turn out positive, the government refunds you. Mm-hmm. Now, then they also opened up testing to private. In fact, the reason why South Korea moved so fast is because they are private developers in terms of lab testing who are given the mandate, unlike America for that matter, where it was restricted. So they actually were ahead of the curve in terms of testing. So they have the capacity to test, and it was opened up to private sector, which means anybody and everybody can be able to test. And they had this mechanism for making sure that the quality of the test is good enough. So there's a form of accreditation. So I think that needs to happen here. Kenya is trying. We have quite a number of KEMRI associated and CDSA associated labs that have the infrastructure. I think what is missing, and this is my personal observation, is that when we got the 25,000 test kits from Jack Ma and 7,000 from World Bank through Roche, we have the test kits because for 2 weeks we are saying we don't have the test kits. Then we got the test kits. When you got the test kits, there are no PPEs. When you got the PPEs, there are no swabs for collecting the sample. I think there's a lack of coordination. And this one I can say honestly, as a patriotic citizen, I think the ministry needs to get its act together. They need to appoint a proper team that coordinates this. Because at the moment, people are operating in their own silos. I think there's, I mean, it's a whole house of bubble. Nobody, people are not really coordinating. Now, in terms of who should we test? Of course, I agree entirely. We need to test healthcare workers because they're the most exposed. If you can test healthcare workers, get them out of circulation who are infected, you'll stop infecting other people. And then you can also keep them healthier because they are critical, because you just don't have enough healthcare workers. Then number two, what they have been doing was proper in terms of the quarantine. Now, people are getting released from quarantine. Make sure that as they get released to the unsuspecting public, they are actually free of the virus. Then, of course, now the contact tracing. Now, the contact tracing, I think that's why the government has been scoring the highest, but probably the approach has not been the best in terms of almost criminalizing what quarantine is, and then not allowing home-based care, because some of the quarantine facilities are so deplorable that people are probably better off in their homes and using nyumba kumi to keep people within their houses than trying to, and it's not sustainable for the government to continue doing quarantine the way it's doing right now. So what the government has done so far, I think it was right. The capacity might not have been as much to test, but if they can focus on that and get them out of the way. And then the next bit now, of course, the truck drivers, other highly mobile people, guys working in the markets, like in Isli, they closed the markets. They closed Isli down. That was the best decision ever. I think that has saved a lot because Isli is high density, high interaction hub. So when we had a few deaths and quite a number of people associated with Isli, the business community there took a decision to close down the place, fumigate it, decongest it. I think as they go back, they must have now serious, stringent measures. And one of the things will be now testing and basically giving people almost a certificate that you have been tested here, your workers in this place are okay, and that you'll be tested on a regular basis. That is one area we need to focus on. The other area we need to focus on, of course, is the truck drivers, as you mentioned. And last but not least, although we don't have schools opening yet, but in my view, we need to start looking at, and Jessica can talk about this maybe as an epidemiologist or somebody with epidemiology background, think about it for the general public as an opinion poll. When you want to know who is leading or who is most likely going to win the election, you don't go testing, so to speak. You don't go questioning all the 40 million people or the 15 million voters. They take an opinion poll of about only 3,000, 5,000 people, and it gives them a pretty good idea of what's going on. So in terms of surveillance, we need that kind of thing. We need epidemiologists to sit down, map out, agree, this is the methodology we're going to use to determine what is the prevalence of this infection across the country. And nobody is talking about that, but that can be fairly cheap to do. Because if we are getting, we're getting about 24,000 test kits next week. We'll have about 50,000 test kits in total, maybe within 2 weeks. How do you use those 50,000 test kits? Maybe 10,000 goes to healthcare workers and the rest. You can just use 10,000 or 15,000 test kits, and it will give you a pretty good idea of which parts of the country are the most affected, are the worst affected, and it can then drive decision of what we're going to do in those sites. Now, you can one of the problems we have as well, and this I'm also speaking honestly, is that at the moment the government is trying to do the testing and do everything on its own, but they can involve the private sector, they can involve the NGOs, they can involve the community, because to collect swabs is not difficult. I mean, in fact, the FDA has just approved self-collection. You can literally collect yourself, swab your nose. You want to get an idea. So in that case, there are hospitals out there, there are private facilities out there that can be recruited in. There are people like Red Cross. They have trained, there's AMREF, community healthcare workers. They can be trained. Give them the PPEs, let them go collect the samples. It will give us a clear indicator, because we might actually be locking down parts of the country when they don't need to be locked down. So we're losing out. And we might actually be giving this partial lockdown in some parts of the country when they probably need to have a total lockdown. So the thing is to have a targeted mass testing. Jessica mentioned the issue of transparency. Transparency is very critical in a pandemic or any epidemic. Unfortunately, we are not having tongue-in-cheek full transparency. We need more information being given. And I think what people have questioned on social media is, for example, of the people being tested, of the results being given, which tests, who is being tested. I think we need that kind of transparency because then that allows people to actually be well informed and make informed decisions. So the long and short of it is testing is critical, and it's going to be critical. In fact, one of the things that made President Donald Trump backtrack is because he was shown by the scientists that they're just not testing enough, and they don't have enough information to then say, let's open back the economy. So it's a grave situation. Fortunately, here so far, so good. But I won't say, and I think that's a point I really wanted to emphasize and I forgot to mention earlier, the fact that our numbers are low does not mean we are out of the woods or we are on a good trajectory. Because if you look at Italy and Spain, their curves shot up within day 35 to day 45. America, for that matter, for a long time, up to day 70, they had nothing literally going on, and everybody was kind of like bullish about it. Then when it started shooting up, it really shot up. So I'm afraid that we might end up with that kind of situation. And if our numbers remain quiet, but things are simmering behind, then it might just explode in a boiling point. And probably that might happen in Tanzania and especially Zanzibar for that matter. Yeah.
Thank you very much, Kalebi. And we have time for only one more question. But I want to get to Jessica with this particular one.
Yeah, I can just make a couple quick comments. Yeah, I think what you said was spot on. I mean, we've started shifting to doing what we call sero surveys. So essentially an epidemiologic perspective on who to sample and trying to figure out what levels of herd immunity are developing, looking at some of our priority populations, like people who are homeless, people in prisons, people in settings that are likely to really propagate the virus, but also out in the general community. Because we need about 60% herd immunity, or 60% of antibody coverage to really have that herd immunity. And that's going to help guide, I think, a lot of our policies. But that does need to be done in a proper epidemiologic manner. And then the other point I just wanted to highlight is learning from prior examples. And I mentioned this a little bit about thinking through SARS and some of the MERS outbreaks. But I've just seen, firsthand in providing care, a lot of the ways we've been setting up our facilities to manage high volume of COVID patients or COVID suspect patients are really lessons learned from people who worked through several of the Ebola outbreaks, people who've worked in cholera outbreaks. And we're applying those exact same lessons in how we coordinate care. Like your point about needing the swabs, needing the PPE, needing the, everything. It's really incredible how much work goes into setting up a proper infrastructure. But we've been doing it. It's been working. It's our new normal. But really trying to learn from prior lessons so that we can do this efficiently and quickly.
Thank you. And actually, that was you almost answered the last question, but I want to put it out very clear to you, Jessica. So, and by the way, before I go to that, so Kalebi, thank you very much for your commercial about the importance of surveys and survey data, because that's what you have to just keep that in. So I really appreciate you for that. So we're able to really make sure that, because data is what we do, right? So make sure we're able to survey the population and figure out, okay, what needs to be done and give insights to exactly what needs to be done, when you have limited resources. So Jessica, basically, this last one, just if you may just, use it to also give your closing words. What are the most serious and glaring pitfalls that have been revealed by COVID-19 pandemic, and how do we avoid them for the next pandemic? Without getting political, how do you avoid this pandemic? But please go ahead.
Yeah, so what are the main pitfalls? I mean, I think this comes back to what we've already said. I mean, we need to recognize we are in this together. This is not, the China virus. This is not, a local response. This is something that we're facing as a global community. And we need to understand what's happening in our own backyards, but we also need to share that with everyone so that we don't need to reinvent this wheel over and over again. If something is working here, let's share it. If something is not working, let's share that too. And that does require overcoming a lot of these political barriers and being willing to share dirty laundry, because otherwise this is just going to propagate and more lives are going to be lost. So I think this has to be an era of openness. This has to be an era of willingness to work together, to be creative, and to overcome these challenges which we have not ever faced before as a global population.
Thank you. Thank you very much, Jessica. So to you, Kalebi, for your closing remarks. And thank you very much for also hammering so hard on the importance of testing, but also the right decision making, using past data and also data from other sources like what Jessica was doing with HIV and figuring, okay, this person could actually represent what we could do and making that hard decision. And you put a correlation between those who make hard decisions or who delay them and those who don't make any decision at all and the consequences of that. So thank you so much for hitting hard on that. And I just want to thank you, Jessica, as well, for bringing that human-centered design part. We never really think about it actively, but you brought it to bear in your slides. Kalebi, your closing remarks, please.
So my closing remarks is one, I'll say, I think the world is doing pretty much better now than we did with the previous pandemics. And the biggest pandemic we have had in recorded history that is properly documented is the Spanish flu in 1918, and that killed almost a fifth of the world population at that time. I think something like 50 out of 300 and something million, which means that we are probably doing much better with the number of deaths that we have right now, despite all the criticisms that are going on scientists and policymakers and so on. But my comment that I'll say, you look at how the countries have fared. Look at New Zealand, look at Hungary, look at Germany, and look at countries like US and UK. Sorry to mention that. But we can learn a lot. I mean, we need to look at data from other countries and let that drive our decision, because we might not have the prior experience. And as you say in Swahili, ukiona mwenzako ananyolewa anza kujitia wembe, anza kutia maji, eh? So if you see somebody else is being shaved, then you start getting your soap or shampoo, because you prepare yourself. And I think that's what we need to do. For us, we are fortunate because things are happening. We need to say, this is going to apply for us, this might not apply for us. And then we need to be also ingenious. And I'm really kind of impressed by Uganda, what they're doing. And people have tried to say, oh, maybe Uganda is hiding information, but they have very serious ethical people there, and they're doing a good job. And I think Uganda is going to be a model. Now, as one doctor says, that Tanzania might be the other arm of the control, where do nothing. But I know in Tanzania, despite it looking as if they're doing nothing, but there's a lot of things going on in terms of hygiene, hand washing, and so on. The only issue is how serious are people going to be? And I think my closing remark therefore will be, we need to really get very, very serious. And as Jessica said, it applies to the entire spectrum of the population, from professionals, from the public to the policymakers. Everybody has to play their part. As Joho also said, it's easier to deal with economic fallout than to deal with death, because we cannot bring the people from the dead. And if people die massively, and that has been shown from data again, which I was reading in the Economist, they are comparing countries that in 1918 areas that practiced stringent measures ended up having a dip in their economy, but they bounced back much better than countries that ignored. They thought they're doing okay, but the death toll was so much, and some of the cities literally became ghost towns. So there's a lot of data, and I'm glad Ajua team are trying to do some of these things, but there's just too much data. And no, we didn't mention the issue of who coordinates all this data. I think that's my closing remark. I'm not a data person, but who acts as a central repository? You don't have data everywhere. I have very good data in my lab here. Government has good data in the Ministry of Health. You have data in private sector. I mean, guys have all sorts of data. I mean, the telecom industry, but is there somebody bringing all this data together, synthesizing it with now in the era of supercomputers? I think those are the things people should be doing. I'm not pitching for you, Sagya, but that's where we are, and I'll close it there.
Thank you. You just did. We're in the era of big data, and that's our forte. But that we could begin for another 1 hour, so I'll have to end it there. So thank you all very much. Thank you, Jessica. It's probably just past 9 o'clock where you are, and we really appreciate you spending your morning with us before you set off for your day. And Dr. Kalebi, thank you so much. You need to go for your break your fast. We appreciate spending your day one of Ramadan with us instead of with your family in the evening. So we really do appreciate you and appreciate you all. We appreciate all of you, our esteemed customers and audience. We really appreciate you coming on board, for your questions as well. Very informative, and you help us also just bring more out of our doctors. And apologies again. So it looks like this panel, everybody was the doctor, right? So our apologies for that if we got a little bit too technical at certain spaces. But it's, this is a serious thing. We need to get serious about it. It's about our lives. We need to get serious. Because it's about for Ajua, it's about staying alive. We're running a Stay Alive campaign. Next week we have a webinar on mental health, because we believe this cabin fever and everybody getting locked down and all these things that are happening will create unprecedented mental challenges to a lot of people. So, next week we're going to run a mental health webinar as well. And this video this was recorded as well. So if there's something you need to catch on as well, you can get the recording afterwards as well. And also you can send it also to some of your colleagues and friends that missed it. Thank you very much. My name is Gilbert, or Dr. Sagir, as the third doctor in the room, EVP for Ajua, and have a great weekend, have a great Friday. And as Jessica said, wash your hands, keep calm, stay safe. Thank you all. Have a great day.
Cheers, bye.